Good afternoon and welcome to this Translational Applications in Public Health lecture, a collaboration between the Institute for Public Health and Medicine and the Northwestern University Clinical and Translational Sciences Institute. I am Corey Bradley, an assistant professor and team scientist within the Center for Dissemination and Implementation Science and the MSS department. And along with a team of colleagues, I also support the visionary efforts within New Cats Institute to cultivate a culture of inclusive excellence through the expansion of our workforce, partnerships, and meaningful contributions of community engaged scholarship. So we welcome you to this dialogue. Our goal is to make space at the end of the presentation for your amplifications and questions and answers from the audience. So we request your use of the Q&A function rather than the chat to submit any questions you have. Today's guest is Dr. Matifadza Hlatshwayo Davis. I say her entire name. I'll shorten it. She lets us affectionately call her Dr. Mati. And Dr. Mati is an internationally recognized infectious diseases physician and acclaimed expert on public health and health equity. She was appointed Director of Health for the City of St. Louis in 2021 and has served as a trusted messenger, particularly during the climactic visibility of the COVID pandemic, called upon for contributions by BBC, CNN, Al Jazeera, other news outlets, and the White House. Highlights of her leadership as Director of Health for the City of St. Louis include leading a nationally recognized COVID-19 response, lauded by President Biden in 2022, having garnered the attention and notable commitments of the CDC Director and its leadership to the City of St. Louis, resulting in establishing the Health Department's first behavioral health bureau focusing on community mental health wellness and galvanizing government and community to generate community-led solutions to the opioid epidemic. Another accomplishment is implementing critical infrastructure as well as rebuilding the morale and efficiencies within the city's public health capacity, including mobilizing academic health systems and community public health partnerships. And I think notably, amidst the intense challenges public health departments have experienced throughout the nation over the last several years, if not longer, her remarkable leadership has grown the Department of Health in St. Louis by over 31% during her tenure. I've had the joy of sitting in a diversity of audiences that Dr. Mati addresses, from small gatherings to large crowds to corner conversations. She weaves an amazing narrative by which we are transported through the legacy of resistance that she received as an African-born woman of Zimbabwe. Evident throughout her narrative is the thread of humanity and resistance required for the science and practice of medicine and the communities of care who broke her power to disenfranchise populations. Expressed by the words of a dear friend who recalls his care experience with Dr. Mati, he says, "Over my 10 years of HIV care, there has been one medical professional who made me feel normal again, an opportunity to thrive and live. Thank you, Dr. Mati." She has courageously positioned herself as a community healer through an ardent praxis of, in the words of our colleague and friend, Dr. Whitney Irie, emancipatory, not just participatory community engagement. Her overall commitment is a personification of the "and" in the Institute for Public Health and Medicine as a word of inclusion, a word of bridging and boundary spanning. She has demonstrated what it takes to animate the "and" as a call for harnessing the collective powers and capabilities of public health and medical health systems, a vital synergy without which our hope of health justice cannot be realized. Dr. Mati, to you personally, I say, because of your vision and sense of mission upon these ravaged borders of our nation, you nourish hope and stand as a beacon and true defender of democracy and justice for all. As tribute to the legacy of your leadership and apropos to the present political shift we are experiencing in the US, I share this excerpt from the book shared with you from your mentor just before you got on the plane to come to the US, a book titled Zenzele, A Letter for My Daughter. And the writer writes, "Mama, what do you think it means to be an African woman?" And mom responds, "It is to be strong, Zenzele. It is to be at peace within. You must always listen to that inner voice and not permit others to drown it out. It is to measure your words, to balance your works with your gifts carefully. It is in some ways to be selfless, to serve others, yet to know and defend your rights to the bitter end. Please help me and welcome and join me in welcoming Dr. Mati.
Whew. If you would give me just a few seconds to collect myself, because I want to just be in the moment of knowing that my career has earned me this position, where a nationally acclaimed expert in Dr. Corey Bradley would become a colleague and a friend and would introduce me that way. I'm also hoping someone from my team recording it so we could update my bio immediately. But in all seriousness, it is such an honor, and thank you, Dr. Bradley. Your leadership and vision that is interwoven into this presentation because of the significant work that you have done on behalf of public health, minoritized communities in St. Louis, is one of the reasons that this work continues. Thank you so much for having me, Northwestern community. I will start to share slides as we begin this conversation. I am so excited to really delve into this topic today and to share with you. I want to ask if you can see screen and if you're seeing just my slides right now.
We're looking at your notes slide as well.
Still notes?
Yeah.
And now?
Let's see. Not yet.
Not yet. Let's try this again. Hold on.
Oh, well, no. We're still seeing those. Oh, there we go. We got it.
Great. It is my honor today to discuss with you reducing barriers towards health equity, the interface of public health and academic medical institutions. I have no conflicts today, but I will start by saying these are the things that I hope you can hold me accountable to by the end of the session. I want to really talk about how to apply public health principles to medical and academic public health studies, examine ways to promote public health advancement through medical education opportunities, propose some equity-based solutions, and summarize examples of what we're doing here in the City of St. Louis's Health Department. But I hope that you will give me just a chance to talk to you about my origin story, because it would be naive to assume that the stories, especially of women, Black women, and Black women with even further intersectionalities as I do as a Zimbabwean-born woman, that story isn't a crucial part to why we lead and how we lead. So that story starts for me in Harare, Zimbabwe in 1982. If I was there with you in person, I would be asking how many people could tell me where Zimbabwe is on a map. That's usually my icebreaker with students. And I then, so it's a 50-50, but most of the time they know. The second picture on the screen is my favorite picture of my mother, who's truly the heroine of my story. A Black woman mother from what you call a low-income country in Zimbabwe, that raised three fierce daughters, two that she birthed and one that she adopted, even though her finances did not make the case for it. My father was plucked from his village at the age of 15 to fight the war for liberation for Zimbabwe. I want to imagine who you were and what you were at 15. Of those of you who have children, if you even believe that it's a reasonable age to be asked to be a child soldier, but that was the task. And he was shipped off to China to be trained in guerrilla warfare because, Zimbabweans, the native Zimbabweans did not have the tools, the artillery, to be able to withstand the colonial weight of what the war would require. He fought for our independence, and we gained that independence in 1980. met my mother, and they had me 2 years later in a new Zimbabwe, a hopeful Zimbabwe, a Zimbabwe in which my mother could become a flight attendant. My father worked in central leadership. But then things got difficult because, as many of you are aware, the significant PTSD and trauma that falls upon soldiers across the globe. My father included, coming from a war that asked of him from the time he was 15 years old until the time he was just over 30. Meant that he did not have the tools to know how to assimilate into society, certainly not how to be a healthy husband or a father. And so that culminated in my mother's bravery in a culture that did not tolerate women self-advocating in this way, divorcing my dad when I was 4 years old. And I remember as a child going with him to bars. That was normal. It was joyful. It would be him and his comrades. In fact, my dad, most people don't even know his given name. He's known as Comrade Mao because a lot of the veterans were given Chinese names of war. So he was named after Mao Zedong, a very well-known general in Chinese history. And so we would go to bars and we would play outside or alongside while our dads talked, but they drank. And they drank because that's how they coped. And they drank as a form of self-healing. And it was that very quiet alcoholism that resulted in my father succumbing to terminal liver cancer when I myself was 15, ironically. And he didn't tell anyone. My mother had divorced him by that time. He was not a very present father, had never gotten those tools, was an amazing human. And I hear about him to this day, what a wonderful human he is, how much he did, not just for the nation, but for individuals. But that was not our experience. And so he died before my mom was able to get us to the bedside because he kept his diagnosis a secret. And I remember, to any of the students on this call, that was the seed that was planted for my why. My why as a physician was because medicine for me was never an academic pursuit. It wasn't because I was smart and got straight A's, even though I did. It was always about hoping that the medical team, the physicians, the nurses, the people in the hospital that my father was at overseas, because he asked to be stationed overseas as a way to hide his diagnosis and get higher level care. The hope was that they showed him dignity. They cared for him. They took care of him in his final hours because I didn't have that. And the guilt that consumed me as a teenager that I never knew, and I was never able to say goodbye or even to work on our relationship, is one that was part of my why. As I grew up, I started to understand why we were called a then developing country or low income country. The fact that our veterans did not have veterans hospitals that afforded them free healthcare, that we didn't live in a country that afforded us Medicare or Medicaid. And that became very, very prevalent and very present of mind as I watched the HIV epidemic in the 1990s as a teenager ravage my country. In the span of years, we became one of 3 out of 5 countries that were neighbors in sub-Saharan Africa that were responsible for the highest morbidity and mortality rates for close to a decade. What that meant for me living in Harare at the time is that I saw our life expectancy rate plummet to 42. I hope some of you are gasping as you hear that number because it's not compatible with a thriving economy. What I experienced was orphans being raised by their grandparents. So it was within that environment that my second why became very palpable. It was not just going to be medicine because of the death of my father. It was always going to be infectious diseases, but an infectious diseases doctor who understood that public health and an understanding of socioeconomic factors in a low income country was pivotal. I didn't have the luxury of just being a clinician. So I knew that I wanted to gain those tools. But it was my mother, the heroine of my story, who made it clear that education and only education would be our pathway out of that environment, that we needed to get straight A's. In fact, I remember being 7 years old and getting a bicycle out of nowhere. That doesn't happen from the kind of household we're in. So I was kind of looking around like, what's the catch? It's not Christmas. It's not my birthday. Why did I get a bicycle? And it came with it a library card because we were only allowed to ride it to 2 places, to and from school and to the library. And it was symbolic of the fact that she really told us that it was education alone that would help us to realize our dreams, and education alone that would get us out of poverty. And so I'm so proud of this woman on the screen before you because she has raised the first Black female physician health director for a major city in the United States. My sister is the youngest lawyer in South Africa for her discipline. And her adopted third daughter, who I consider a child myself, my child myself, because of the 11-year difference, is a brand strategist and owns her own company, a testament to my mother's will and the will of Black women across the globe. I then came to the United States to realize this dream. I wasn't able to pay for university, so I was able to get one full scholarship. I got a partial scholarship from Princeton because I played field hockey, but partial wasn't going to cut it when you don't have money. And so it was Drury University in Springfield, Missouri, that gave me a full scholarship. So that's where we went, because Oxford said partial, a couple of other colleges across the globe, but the only one that afforded me a full scholarship was Drury University. And I remember driving on a Greyhound bus into the cornfields of Springfield thinking, oh my God, where am I and what will happen? And the 4 years that I spent there were some of the most nurturing and safest in education. Because unfortunately, when I went to medical school, the affirmative action movement started, and what was absolutely necessary, backed by data, was not always safe when you are tokenized. I was the only Black person, one of two actually in my medical school class, the only one in my fellowship. And as a pattern, it became a pattern of, I wasn't allowed to use the race card, but it was used against me, right? She only got this award because she's Black. She only became the associate program director because the division director was smart enough to hire a Black one. And so I started to lose myself. And I was very honest about who I wanted to be in medicine. I told you my origin story, a physician rooted in public health, wanted to be an ID doc, but certainly embedded in the central tenets of what it means to be justice-oriented, community-minded, and to lead with a lens of health disparities. But I was constantly told, you don't say that because that's not how you succeed in academia. You don't do that because only basic scientists and clinical researchers thrive. And unfortunately, that became my experience. So I became a shell of myself as I wasn't seeing people that look like me in the institutions that I was being trained in, and I certainly didn't see people who were doing the type of work that I valued. And so even though I became the youngest ever direct Board of Health member in St. Louis, even though I was on over 60 community-based education endeavors, I was speaking in barbershops, I was the only visible presence in our division, that didn't translate to equitable advancement and promotion. I was not being advanced at the same rate as my colleagues were, and I certainly didn't see it. So I finally resigned in self-advocacy, and I was told my career was over. You don't leave the big institutions and live to tell the day. But 4 months later, I became the director of health for the city of St. Louis in the middle of a global pandemic. And that was because the community knew my name. During that time where I was struggling, I was in community doing the work. Even though that didn't always translate to evaluations, the community knew me. I built a trust. I went into community not saying, listen to me, because I come from this amazing CV of institutions, but please can I learn, train me, help me to understand what it means to be a leader on behalf of public health center and community. So in 2020, I found myself prior to me resigning, I was a infectious diseases physician on faculty, pregnant during this global pandemic. Then 2 weeks into lockdown, when I had just given birth, breastfeeding every 2 hours, George Floyd was murdered. And it was then that everything changed, because as a new mother who was breastfeeding herself with a 3-year-old in lockdown with no family to help because everybody else was on lockdown, I could not bring myself to watch the video of yet another Black man being murdered in broad daylight. But it did something for me, as it did for many leaders from our community across the country and even the globe, where that was the call. I no longer was going to wait for that advancement and promotion in my institution. I made it clear what I was asking for, and it didn't come, I did leave. And it was when I returned that I stopped listening to that imposter syndrome in my head. And before I left for maternity leave, newspapers and journalists in the St. Louis area kept asking me, could you comment on the COVID-19 pandemic, especially as a woman from a minoritized background who is an infectious diseases specialist, we'd love to hear from you. And I'd always say, no, not me. I'm not senior enough, right? I'm not good enough. I haven't done enough. And I would punt But when I came back from maternity leave with that new calling, with that new understanding of what was required of me in this next evolution of this country, in this pandemic, and truly as a unicorn, right? A Black woman, immigrant, infectious diseases specialist trained at some of the top institutions in the country, the community needed me because by this time, the statistics were overwhelming. In my community and in minoritized communities across the country, we were 3 to 4 times more likely to get COVID, three to four times more likely to be on a ventilator, and 3 times more likely to die. And it wasn't that that was surprising. It was more the frustration with the righteous indignation and the shock and awe of that across the country when we've been seeing this for decades. High blood pressure, diabetes, most cancers, all cause mortality. This has been a copy and paste, and it became frontline once again in the pandemic. And so I made it a point to now, whilst breastfeeding, one of my favorite pictures, and I don't think it's in this collage, is of me breastfeeding my daughter with pajama bottoms and a really formal top before I had to be on MSNBC 2 minutes later. And it was using those platforms, first national and then global, as you heard in my introduction, to really advance the central tenets of health equity for the COVID-19 pandemic, to be a representative, because representation does matter, and to get letters, literally handwritten letters, and people in my DMs across the globe to say, we have never been seen and never had someone from our community who is an expert help us. And so that is really central to my why, to my how, and to how I then joined the health department in October of 2021 to lead them through this pandemic. So let's talk a little bit about what the state of public health was when I did answer the call. Because COVID-19 at that time did thrust public health into the limelight. We were the implementation arm of public health. Health departments were tasked with the disease tracking of this novel virus. Capacity reaching vaccine distribution was the call in early 2021. But at the same time, the public health workforce was burning out after being on fire, deprioritized globally, nationally, at the state level, and certainly locally where it matters most. So let's look at what that looked like. This data before you is one of the things I looked to at the beginning of my tenure in October of 2021 at the city's health department. It's a 2021 Public Health Workforce Interest and Needs Survey, PH wins, that shows the public health workforce. As you can see by the summary on the page, it's primarily a white workforce, primarily female and over the age of 40. The workforce has become more diverse, however, which is encouraging, and mirrors the US population more. However, there is less diversity at senior levels, and 66% of all executives identify as white. We're also quite literally bleeding, as nearly 1/3 of state and local health employees at 32% said they were considering leaving their organization in the next year from this survey. We lost 150,000 public health workers at the end of 2021, projected to be 250,000 by 2025, just next year. So I was thinking to myself, as I started to take the call, that I need to also use my position to advocate, that I need to come up with a new, novel, never before heard of public health strategy. But I was shocked to find out that we've had one, literally since 1988, because supporting public health is nothing new. 35 years ago, an Institute of Medicine report titled "The Future of Public Health," this is a book that was published through multiple national agencies, including the CDC, HRSA, and other research entities, laid out the map work. And gosh darn it, I read it and I said, this is applicable right here today. So I'm going to be very open with you that sometimes it's important to understand our history, which is why I start talks with my story, which is why I'm bringing this book to the fore, because this book shows that it has been a willful negligence and deprioritization of public health, because we have had the blueprint since 1988. And I can tell you that outside of some innovations and novel breakthroughs, there is nothing that we need to veer from here. So I'll be using this as the backdrop for my talk today. Because in this book, it talks about the fact that academia performs 3 important functions in public health. 1, to conduct basic and applied research in disciplines pertinent to public health. 2, to train and educate public health workers. And 3, and most importantly, in my view, with a very clear and unapologetic bias, is to engage in community. Let me say that again, to engage in community, public and professional service. So let's begin with the funding aspect of the first aspect of this book, which is research. And the funding and research in social and structural determinants of health. At the time of the report in 1988, public health expenditures had been declining over the past decade. Only 1 to 2% of funding was being spent on prevention. Fast forward to 2013, as you can see on your screen, and the Network for Excellence in Health Innovation found that only 6% of national expenditures were spent on making care accessible, while a whopping 90% of national health costs went to medical services. This is not how we get to the goal of a public health agenda that is locally driven and implemented that centers health equity. At its core, disease prevention relies on science. We know this, particularly science that predicts what will happen if we don't act. Currently, the NIH invests much of its $45 billion budget on medical research. That's 83% of that extramural research through grants, while only 11% is for NIH scientists. So looking at the graph on the left, about 20 years ago, we saw a shift where we were spending per capita on healthcare expenditures started to supersede the percentage of NIH expenditures. Funding influences stem from opportunities for professional development, with nurses and doctors making up 11% and only 1.3%. Let me say that again, only 1.3% respectively of public health workforce. Again, and you'll hear the same message until it's drilled into your subconscious. We are the implementation arm of public health. I gave this same talk to the NIH for their grand rounds last year, and I said it to their face because I will stand 10 toes down on my message. And I say to you quite simply, how can we spend billions of dollars on this much needed revolutionary research if we cannot compel people to take a pill or a vaccine? While the NIH funding is split heavily on extramural research, when broken down between basic and applied research, over half of NIH's research funding supports basic research. That works fine when you're just looking to advance knowledge, which again, I'm not downing, that's necessary. But when it comes to finding a solution on preventative care, less funding impacts not only those affected as a community, but also down to an individual's specific needs. So, what does this book say about its research recommendations? It says federal funders of research and academic institutions must recognize and reward faculty scholarship related to public health practice research. We don't see enough of this yet. If we can increase budget allotment to population-based and community-based prevention embedded in health equity research, it will allow us to address population level health problems, to focus on behavioral and environmental, socioeconomic, structural, cultural, and physical factors that are associated with primary and secondary prevention of disease and disability in our communities. Okay, deep breath, you're hanging in there with me. Let's move on to education. So what do they have to say? And a reminder of where public health work is historically rooted. Public health in the United States actually dates back to the late 18th century, where the creation of the Marine Hospital Service began. Early on, and still today, public health works to improve sanitation and cleanliness, ensure safe food and drinking water, control infectious diseases as they arise, and provide critical vaccines, especially to children, but as we've seen over the last couple of years, to anyone and everyone who need them. If we cross-train medical and public health students, both begin to understand the importance of epidemiology, biostatistics, public health policy, and elements of prevention, that is where the call in education. Academic institutions have the opportunity to help train our young professionals following these recommendations by the Pew Health Professions Commission. So first is to increase integration of interdisciplinary learning opportunities. The pictures before you was how I did this. When I came on in October of 2021, I had 2 weeks to figure out a comprehensive pediatric rollout for the city of St. Louis. I went to my emergency preparedness team, there were 3 people. 3 people, that wasn't gonna do it. So we had to lean into our academic partners and our state level volunteer bases to put together, to this date, the largest vaccine effort in any city in Missouri. And we did this through that integration of interdisciplinary learning opportunities, going to our schools of nursing, going to our medical institutions, going to our federally qualified health centers and partnering with our state partners. We need to train public health workers in a set of core public health competencies, but also provide opportunities for practical experience. So many times I get in my inbox, right? Everybody across the country wants to be my intern. But usually it's students who want to put a checkbox on their CV, who also are tired, so they use their intern opportunity to suddenly get sick, get COVID, everybody's dog dies, right? And they are a nightmare for my team because they do all this work to individually train these folks and they're not available. No more. We are calling for academic institutions like Northwestern to partner with your health department. Do you even know the address to the health department? Many of you on this call when was the last time you went to their website? Do you know what their 3 priorities for 2024 and 2025 are, right? And what are you doing to enhance those? One of the things that I am doing and have called for, and I have 2 MOUs now, is for academic institutions to provide and pay for, because that is the work of reparations. That is the work of reparations. 20% of the salary of their own faculty members, so that their faculty members can bring in line their students, babysit them on our behalf, and make sure that our shared priorities and agenda and deliverables are manned by them. That is how you support public health. And not like what an institution did to me a couple of months ago, sending me a pre-written MOU to serve their Institute of Public Health so they could check off their checkbox for the NIH grants that they need. No more. Right? So these are some of the ways we can start to work together in partnership and really work on these struggling workforce capacity issues that we have in public health. The last thing that this book called for was to provide service training opportunities. So there's a real opportunity here to think about what your curriculi looks like across Northwestern, and if it is really serving your prioritization. And I know you're serious about this if you would be brave enough to hire a legendary activist and someone who doesn't make it easy for you, and Dr. Corey Bradley. So I know you're serious about this work, but you can together start to really reimagine what a medical curriculum can look like, right? And really start to bring it into what it needs to be in 2025, not just a copy and paste version of what we've been doing in education since the 1980s and 1990s. So this is the picture, I'm sorry, that I was alluding to, where these are the volunteers that we were able to get through these partnerships and MOUs to really increase our reach. And to this date, this health department has given over 45,000 COVID-19 vaccines in an environment that was really not supportive. People use the term vaccine hesitancy. I refuse to use that. I find it offensive to minoritized communities because there's nothing offensive about valid mistrust and distrust that dates back to slavery, when the bodies of Black people were used without consent in abhorrent research. When we think about Tuskegee and the children and grandchildren of folks in Tuskegee live to this day, and I took care of them in clinical practice, and they cited not listening to us or not trusting us as a reason when we think about Henrietta Lacks, right? And so these partnerships are critical in earning that trust. And in our term that we use here at the health department is not vaccine hesitancy, but instilling vaccine confidence, because that puts the onus on us to earn the trust of the community, right? So what can these service engagement looks like? Academics and institutions can provide these collaborative support through community service to state and public health departments in the way I just defined. Policy guidance is a huge one. I was teaching at St. Louis University's law department. I do one of their introductory lectures on the interface between public health and law. And that birthed an MOU that we're finalizing right now for us to be able to have Northwestern again do their part by paying 20% of time of the JD MD, so a lawyer who's also trained to be a doctor, to head a policy agenda that supports my department, right? We bring in a community-based organization to keep us all honest with what the priorities in community is. And the mayor was good enough to hire a policy czar who gives us sort of guidance through both local and state initiatives. And it is because I have him and all his graduate students that I've been able to have a policy agenda that, quite frankly, in a global pandemic, I've had zero time for. I have no way to look at if my old policies were correct, and certainly not to address the new policies that were needed when marijuana was legalized in the state or when they came for trans health, right? And so policy guidance is another way that Northwestern can really make these critical partnerships. The last thing that is called for here is service to the profession through peer review, participation as offices of professional association, and serving on committees within academia and associations. So I gave you some examples already. I get ahead of myself when I'm excited. You can tell that this is my passion and my life's work, so we can move on from this slide. So I want to give you some examples of how I have intentionally embedded health equity into this agenda and what that can look like for you. This is one of my favorite diagrams, and I'll have this reference for you to cite, to utilize afterwards. But really it calls for academic medicine and partners focusing on efforts to address systemic, structural, and measurable and avoidable health differences in populations, specifically in minoritized communities. And it calls for 5 ways we can do that, right? Number 1, developing a network of collaborators. And let's talk about the word collaborators. Collaborators isn't academic institutions going into community with a condescending top-down approach, because we assume that we, the academics, are the ones they have to learn for. It is going in with a truly collaborative approach, saying we need to learn from your expertise and we humbly bring ours, and together let's build a shared agenda of prioritization that isn't pre-built just to fit our needs as academics. That's what developing a network of collaborators means. It means optimizing use of new data platforms. The work of health equity is so disenfranchised that we don't even have the right metrics to be able to measure it. This is how even the trans community, as another example, have always been left behind and experienced such violence at the hands of government and health institutions, is because we don't even have metrics that we have dedicated, as we have to other areas of medicine and science, to be able to really track and build public health and research agendas to support the community. We need to develop transdisciplinary training platforms. We need to embrace inclusive research teams, even basic scientists who know darn well that they have no business, right, speaking at a mic on behalf of health or public health. They don't have the tools, child. They don't have the skill, okay? Even they, though, can build inclusive labs and look for research grants that empower them to work in a in a truly collaborative space through translational work, to really make sure that the critical work that they're doing at the bench and within clinical research is ready to be in community. I'm going to give another example. I love my colleagues, but when I was in academics, nobody talked to me when they were building their protocol or applying for their grants. Nobody reached out then. Nobody reached out when they were building their protocols for their research. And then they went through all their clinical phases, and then their outcomes come. Then I'd get the call. Hey, Mati, my favorite only Black colleague on staff. I've got these results for my trial, and I now need the Black community to really sign on to what I got going on. So would you sit with me at a press conference? I know I haven't talked to you in a year or even asked you how you're doing or what I could do to help your work, but I just need a Black face to help me with some Black talking points, right? I often get the call, hey, I'm about to apply for a grant, and no, I don't want to honor your expertise and include you in the grant, or even, God forbid, think about how we can pay community members. What I want you to do is, can you just get in your Rolodex and get me about 10 to 15 Black leaders who you can introduce me to so I can quickly put them into my grant and hit my checkbox? That's what we're not going to do, right? That's 1990s. We're 2024, and we're inclusive and we're thoughtful here. So even with your colleagues, how are you approaching them, the Dr. Corey Bradleys and others that you're so fortunate to have? How are you leaning into their expertise? How are we protecting their time? How are we advancing and promoting them equitably? How are we making sure that their collaborative work that really honors you and community and is helping to bridge the divides of that valid mistrust is being utilized appropriately? That's what addressing health inequities must and should look like in academic centers. And so this Googleable pictures that everybody has seen, but oftentimes the last slide is left out, is how I speak about this in community. I say to them that the reality is that minoritized communities have not been able to thrive. And I use a baseball game analogy because that's where it comes from. Leave us alone. We don't want to talk about politics from our places of privilege, because it's a privilege for me to watch the Sunday game and turn off the fact that I am struggling in every other aspect of my life to pay the bills, to drive to my doctor's visits, to all of the above, right? And equality tried to get there, but equality said the fair way to do this is to give everybody the equal resources, but that doesn't cut it because not everybody still has an opportunity to thrive and to watch the game. So equity must be the way that we do this. And when the mayor interviewed me, I was clear that unless she was comfortable with me leading on this platform, and thankfully she does too, I'm not the person and they should probably find someone else, because our shared goal should be liberation. Liberation for all communities, for all people of minoritized background, because we haven't done the work of public health that we value so much if we leave anybody behind. And this is so true when we think about the path ahead for the next 4 years for this country. So what have I done to address that? Well, I decided that we wanted to be one of the leading cities in the country to build a health equity plan, the first of its kind, comprehensive internal and external facing health equity plan for the city of St. Louis. We went first to our local experts, including the Center for Implementation and Dissemination, and a consultant that you may know the name of by the name of Dr. Corey Bradley. And we built the framework for this. He has since left and came to you all, but he was really happy to see this work come to fruition that he built the foundation for now, how many years ago? 2.5 years ago, Corey? Yeah, I think 2.5 years ago when this started. We have a 96-page comprehensive health equity plan for the city of St. Louis, a 12-page primer. We are training all aspects of our executive leadership team. We are training. It is embedded throughout our programs, and it is external facing. And I want to use this as an accountability tool and a framework for the city, and then invite counties around us to make this truly a regional effort. We brought in the folks that built the health equity movement from the city of St. Louis, from the Ferguson Uprising, the Regional Health Commission, the Integrated Health Network, honoring their expertise as well. And it was they that took the foundational work of Dr. Bradley and the Center for Implementation and Dissemination at WashU and brought it through to completion with this document. And again, it was because we understood that in order to do this work, it must be community driven, community started, and a community participatory work. I often use a quote of Dr. Bradley's that he's so frustrated with me using because now he hears about it everywhere. And he said something to me that just, I've told him if he doesn't patent this, somebody's going to steal it, which is data is justice. And I used to use it and beat on my chest and feel really good about myself, like I was saying something really revolutionary that my friend and I heard. And I remember we were doing a community event downtown. And if any of you know the TV program that LeBron James has called The Shop, it is on HBO, and he reproduces a barber shop and invites Black leaders, especially in sports, to talk about it. Was his response to the shut up and dribble. And he was like, watch this. And so they talk about priorities in the Black community. So we reproduced it for our Ending the HIV Epidemic program, inviting HIV leaders from the community to a Black barber shop that has the most beautiful Black art. And I said, data is justice. And a community leader next to me started laughing. And it was a really kind of rude laugh because it was from his belly. He laughed hard at me. And I said, what's funny about that? And he said, you academics love your data, don't you? And he said something to me that I often reflect on with my epidemiology team, that I grew from 2 to 11 in my first 6 months because of how important I truly believe that phrase is. Data truly is justice. But what this community leader said, if you control the variables, then you control the outcomes. And I'm going to say that once again so it really sticks. If you control the variables, then you control the outcomes. He said, you never come to us first, kind of like the example I gave when my colleagues would call me in academia. So by the time your outcomes come out, they have no bearing, significance for what is really going on. What my call is that we must start together. And so this health equity plan is the beginning of really trying to set a roadmap that says that community participatory approach means starting with, listening to, driving the agenda for the protocols for the grant applications, working alongside those community leaders so that when the outcomes come, there is already an organic collaboration that can serve the community and hit the ground running from an implementation perspective. So I don't have a lot of time because I talk too much, but I talked a little bit about the examples of what we're doing from an innovation. Unfortunately, I inherited less than 1% of the city's budget. And in Missouri, we are 50th out of 50th in per capita spending. We only spend $7 per capita on people's lives in this state. So the level of disinvestment here was great, and I had to be innovative in approach. So in COVID, 45,000 meant leaning into those collaborative partnerships and volunteers, but it also meant from a health equity lens, never asking someone to come and get a shot downtown here at a building that may not feel safe for many community leaders. And with a survey that we did here, that on average takes 3 modes of transportation: walking to a bus stop, to take a bus, to take another bus, to walk to the health department or to a doctor's office. So we held our clinics at the trusted messenger sites. We were at Casa de Salud when we needed to reach out to the Hispanic community. We were at rec centers. We partnered with the Board of Aldermen and went to their neighborhood meetings, and we were in community giving those vaccines throughout the COVID-19 pandemic. This lays out the MOU that I talked about later about how we address advocacy. So I'll flip over this. So I'll end by, what do we need to do now as measurable steps to support these 3 tenets that 1988 book laid out for us? So the first thing I would say for the basic research is we have to really commit, right, to the research that will help us to develop vaccines, innovative treatments, but with a public health lens. And that includes a prevention research agenda, community-based research agenda, and translation of research findings into practice. We need to find and allocate resources. And this is where I spoke directly to the NIH about really thinking about what percentage of funding goes to studies that specifically and with intention and unapologetically address public health and health equity, requiring equitable mentorship, sponsorship, advancement, and promotion. As it pertains to, we need to have a community first approach, right? In our academic centers, physicians and public health leaders cannot only treat patients in front of them, right? We need a medical education agenda that teaches the social mission of medicine and public health, that makes hands-on public health work part of mandatory training, and that scales up programs, encouraging graduates to enter underserved areas using some of the innovative ideas with the MOUs I gave you. Medicine and public health need to have a social mission integrated into every aspect of training. This needs a radical overhaul of curriculum. I am the consultant for Washington University now, and they have completely radically overhauled their education, and is the only reason I now choose to lecture there as a part of the solution to the problem they were brave enough to address. And then I do believe that academia needs to recognize population health, but more work is needed to transform it, right? Capacity for leadership and partnership with the collective impact model, acting as teachers and scientific interpreters, providing technical assistance to public health departments, because I'm telling you, we need it. You heard me, I said less than 1% of the budget here in St. Louis. Developing prototypes and evaluating programs like CABs. Community advisory boards are one of the bane of my existence, because we have not really looked at them to see if they really serve our research agenda. I'm coming back from a 2-day visiting professorship at Emory. They have one of the oldest CFARs, and they blew up their CAB. They have a community advisory complex and much more partner-driven model that if you're interested, you should reach out to their CFAR to hear about what they are building there. And I got to meet with members from the community, and they are some of the roughest people to make happy, and they still hold them accountable, but it's much more of a partner-based approach and not just a checklist. And then disseminating effective practice, because it is time to significantly invest in a physician public health practitioner approach, teaching, innovating, and above all, focusing and building actual pillars, actual entire departments and schools of public health that are just practice, and that we are not gaslit in those academic institutions with, if you haven't published 100 papers, you're not successful. Practice professionals such as I, and I can tell you that my work has been as impactful, if not more, than people who are only held accountable by the number of PubMed numbers that they have. So I will close with this quote, and this is especially for the young trainees that are joining us today. When I announced my new position on Twitter before it became XYZ, whatever it is today, I went viral. And I think it's because this quote resonated with a lot of people. It comes with this picture, which was one of the newspaper articles that was announcing my new position. One day I will tell my story in full, but for now, trust your instincts, know your worth, be brave enough to forge your own lane if it does not exist. Choose your mentors, and I will expand that to sponsors as well, wisely. And above all, do not be afraid to step into your purpose, because even on weeks like this, where the work seems overwhelming, it is still absolutely beautiful to live and lead in your purpose. Thank you so much for having me.
Wow. You're stellar. Oh my gosh. Mm. Please let me invite folks to share questions or resonances as we spend the next few minutes being further and more deeply nourished by your words, your insights, Dr. Mati. Like I'm so grateful to hear articulated and elaborated the things that resonate so deeply, and I think are a matter of social change and transformation. I have a quote here in my office from Toronto Fisher. Their definition of care is everything that is done to maintain, continue, and repair the world so that all can live in it as well as possible. And I am so happy that you are bringing to the fore that the notion of care is not just within the interpersonal or clinical dyad, but is also a matter of how we hold the conditions that people are living through and how we can use public health and the partnerships with health systems to be able to effect change in those spaces and in those ways. So just thank you so much. I'll get started with one of the first here. And folks, yeah, I'll read. Given the results of our recent election, I'd love to hear your thoughts on how we can work with our existing partners in order to be agents of healing. Mind you, I sincerely believe, the person writes, that now more than ever, security and progress lies exclusively with community and no longer can be relied on as an interest of our government. I hope this makes sense, the person offers. What
Yeah.
thoughts there?
Thank you so much to Marquita Lewis. I want to start by saying that because comments are disabled, please not only put questions, but just your comments in the chat, as we'd like to celebrate them, read them, and really get into them. And Marquita, I'm going to be very vulnerable and transparent that I hold space to not have the answers today as a Black woman, especially this week. I have been telling other and my mentees, scores of other Black women who are in a lot of pain and a lot of just reeling from this, that I want to encourage you and others who may feel similarly, and those who don't. I understand if you don't, but those who may feel similarly, that I just get to take care of me, my kids, my husband, our family. I think that that is the most reasonable response I can give this week, because I do know that I am firmly embedded in the work as I have been across multiple administrations, but that requires me to make sure that this cup can become full again, that I can heal, and that I can respond. So I will start there, and I thank you for your affirmation, Marquita, in the chat as well. But a few further reflections as I start to think about what has rooted me here and what this time calls for is patience. Because with any, and the Vice President Kamala Harris was extraordinarily gracious in her speech yesterday, and really talked about the fact that the work and the fight was never embedded in one election, and I feel that deeply as someone who's been doing this work. And she also talked about her commitment to a transition, right, of power. And I think that all of us that are leading in this space have to be committed as well. A lot of things were said, ranging from reasonable to the ridiculous and absurd, specifically as it pertains to health and public health, specifically as it pertains to who was going to be given leadership over health and public health, quite frankly. So I need to see what was grandstanding and part of strategy just to win an election, and what is going to be rooted in fact, so that we can build a strategic plan within our spaces. So what I would encourage all of you is be thoughtful about your personal healing, your personal joy, if that's where you're sitting at today, and first, and then start thinking strategic, then listen and wait to see what leadership is saying at the national, state, and local level, and then think about your strategic plan about how that will frame your work and what is required of you. I will say that I will no longer be called upon to be a martyr. That's something that I refuse to do, because I do believe that the resentment that can build up as a leader is not healthy. But what I've done at the City of St. Louis's Health Department is being committed over the 3 years. One of the things you heard in the bio was a 31% increase, despite that less than 1% 2% of the city's budget, building critical infrastructure, getting out of every red and high-risk audit that I inherited and millions dollars of debt that I've paid back, is because I wanted to make sure that no matter if I was sitting in the seat, no matter who was sitting in the seat in the mayor's office, and certainly no matter who was sitting in the seat in the White House, that the health department could still do the work that the community needed. So I encourage leaders to make sure that you're focusing on systems work that is embedded in community and health equity, so that it is never, so that me leaving will never be what cripples this health department. You know, there's oftentimes even employees in this health department that love to remind me, well, I'll leave with my amazing self. And I'm always like, with gratitude and with love, but with a lot of boundary setting, you can go, because I have now put this health department in a position where I could leave and they should be okay. My commissioner, who's amazing and has a different skill set from me, could leave and we would still be okay. And where any manager, supervisor, or employee could do the same. That's what leadership must and be, so that we are not wavered, right? Or the work is not diluted by who is in power at any level. So be thoughtful about that as you take time to heal.
Shay, you know, to add to that, the measure, I think one of the things I pull from your talk, the measure of integrity within our community and for health systems is the intentionality with which we advance public health and hold the interest of public health, and the responsibility of health systems, to Marquita's point, to come in where there are gaps, where the intention can be magnified or amplified through us working together in that kind of way. And I find that to be really powerful. I think Northwestern has celebrated, and I spoke with a colleague about the record-breaking winning of awards and grants by the NIH. That means nothing if our communities are not, if we also do not frame this as saying we won, right? The city of Chicago won this much money in grants, and look at the kind of impacts and outcomes that we see in our community. So I adore that. And I think this next statement or resonance from Anna Marie Doyle highlights data is justice. But if we control the variables, we control the outcomes. And Anne says, I work in the ALS space, and my goodness, does this resonate? We could do so much better.
Dr. Bradley, did you see what Anne-Marie just did for us? Combined, honey, for the ultimate quote. Let me go ahead and get this money for you. Oh, my look at God. Thank you, Ms. Anne-Marie. But in all seriousness, thank you for making that connection and for your active listening and making that connection on behalf of your work.
Absolutely. That's phenomenal. And I love the idea that we are kind of co-defining problems with community, right? There's this sense that we have a sense of what the problem is as biomedical scientists and experts, but to your point, that's interpolated in our variables and then our outcomes. And so maybe it's not the problem out there, it may be in how we study with community. So a couple of other resonances. Thank you from Larissa Rugg. Thank you. I second fighting back tears, no question, just sending praise. Rachel Moore says, I'm so grateful for the work you are doing and will continue to do. Thank you for your incredible transparency and candor regarding these vitally important topics. And I mean, if you do not know or understand the meaning of speaking truth to power, you know it now. Yolanda Cawthron, hi, thank you both. This has touched me in many ways. I am not a clinical program coordinator, but wanting to do more in my community, and that is golden.
And may I speak very quickly to Yolanda? One of the things that's irked me when I was a physician in academic spaces is this idea of hierarchy of positions. I had the highest retention rate in my HIV clinic, and I was gaslit by a leader that told me, oh, you're successful because you're Black and most HIV patients were Black. And the demographics just weren't true because my retention rate spanned all races. It was just excellence over here. But one of the things I did in order to have that retention rate was to understand that my position was as, if not sometimes less important than my social workers, my nurses, my community health workers, program coordinators like you, who have way more face time, that have touch points. And so I would bring them into the clinic as opposed to making my patients, who had again walk to a bus stop to take another bus to walk again to clinic, made to wait in a waiting room for 40 minutes before being put in a room, seen by a student, before getting a quick 15 minutes with me because I was running behind, then made to wait again to wait to get their labs and are just desperately waiting for somebody to give them a voucher for their bus pass home. The system is broken and must be fixed, right? And so it's folks like you, please don't just say, I am not clinical, right? As if you need to explain yourself. Your position is so critically important in research and clinical practice and public health practice. So I just wanted to honor your work and the work of the multitudes of public health leaders who are equivalent in importance across the space of public health. I just wanted to salute you today, Yolanda.
You inspire me. We must conclude, and I just want to add also that we must remember that systems are a matter of relations. And so I think your point to Yolanda points that out so well. And we can't spare anyone in this movement of health justice. Everyone, come back to this video when you can, especially in these really intense times. Come back to this space. Come back to community with folks. I know we're in Zoom, but get yourself a Mati, right? Get yourself a Whitney Irie, get yourself someone, get yourself a Marquita, someone who can stand with you and think with you and reason through this with you. I think that is the conclusion. I don't know if there's any other benediction that's needed, but y'all be good, be safe, be strong.
Thank you so much for having me and for your leadership, Dr. Bradley.
Yes, absolutely. Thank you.